Hello, hello, and welcome everyone to today's VMR. So nice to have you all here. Today it will be Ravi and me, and we are very honored that Yusuf and Nidhi volunteered to present the case today. Ravi already texted 5 days in advance that Yusuf has a case and it will be tough. So yeah, I think we will all learn so much today, and thanks so much in advance. And thank you also all to be here today. And yeah, maybe you want to introduce yourself, Nidhi and Yusuf.
Yeah, sure. Hi, everyone. I'm Nidhi. I'm a current first-year intern at Emory. I'm originally from South Florida, and I moved up here this year to Atlanta.
Yeah, and I'm Yusuf. I'm also one of the residents here. I'm interested in clinical reasoning, infectious disease in general. And I just want to add to that Nidhi was an intern on my team, and she was always really, really caring for her patients. That she went off service, and then this patient was hospitalized, and I saw them, and Nidhi was off the team and came and checked in on them, talked to the patient, even though she was not on service, and it just shows how caring she is. And I really wanted to present a case with her because of how hardworking and caring she is.
Wow, that really speaks for your patient care, and I think the patients can be happy to have you. Yeah, Ravi, how are you doing?
Oh, I'm doing wonderful. I'm really excited to be here today to co-discuss with you. The brilliant and masterful Sammy always has a lot to offer. So hopefully, if I stumble along this diagnostic journey, Sammy will be there helping me pick me up and move me along. So, and yeah, wonderful to have Yusuf, a new CPS team member, bring a case, and Nidhi, soon to be PGY2. Are you excited for a second year? A few months away.
I'm nervous. A lot of people have started saying that now you're almost a senior. So I think it'll get a little getting used to, but I'm excited.
Excellent, excellent. It's always an exciting part of the year, but yeah, nerves always there, but you just hit the ground running first day of PGY2. So yeah, you'll definitely crush it. No worries, like Austin mentioned. So shall we begin with the case and deploy the whiteboard?
Sure. So our chief complaint for this patient, we have a 39-year-old male who came in with 2 weeks of progressive weakness in his shoulders and his hips, as well as 1 week of intermittent chest pain.
All right, wow, what an intriguing chief complaint. So we have bilateral weakness in the shoulders and hips, and intermittent chest pain for 2 weeks in a middle-aged man. So first, there's type 1 thinking and type 2 thinking. When I heard bilateral weakness in the shoulders and hips, I immediately thought about polymyalgia rheumatica. But then the demographics of the patient don't really fit too well. Normally, you would expect that women in older age, about 50 or something. But I would still keep it in the back, but step back and think what other causes could cause this weakness in the shoulders and in the hips. First, I want to do a physical exam and check, is this really is this objective weakness when I examine them, or is it just a feeling of generalized weakness would have a completely different differential without really weakness on physical exam, called asthenia, which can occur in many diseases and is very unspecific. But if this is true objective weakness, I would mostly you can think about from the brain up to the corticospinal tract, the internal capsule, the spine, the peripheral nerves, the neuromuscular junction, and the muscle. And one pearl is that when you have proximal weakness, it's mostly going to be a myopathic process, versus when you have distal weakness, it's mostly going to be a peripheral nerve or neuropathy. And so when I hear that, I mostly think about, is this a myopathy? Is it inflammatory or not? So a CK is going to be interesting. Other signs and symptoms of myopathy, dysphagia, stuff like that. And when I try to lay that above a schema of chest pain, I immediately thought about which muscles are in your extremities and in your chest. And there's the heart. Could this patient have some kind of inflammatory cardiac myopathy or something like that, which could be an overlap syndrome? But always staying basic, what are the life-threatening causes of chest pain? ACS, aortic dissection, PE, pneumothorax, esophageal rupture. But I don't know, maybe this is getting like a little bit of a pericarditis flavor to me. I would certainly ask about positional changes. Is there pleural chest pain, which would heighten my suspicion for like a pericardial disease? Yeah, Ravi, what do you think?
Oh, absolutely wonderful. You covered a lot of different bases there. I think it's early. I don't want to diverge too much into a rabbit hole of maybe some possibility that probably is not connected to this and just overextend my cognitive load or my thinking. So I think there's two things that stand out to me. So chest pain, like you mentioned, system one thinking, or just using commonly heuristic thinking. Chest pain go through the 4+2+2, but you have something here that is moving us out of just the cardiac or the upper extremity region to a systemic process here. So like you mentioned, pericarditis, could there be inflammation that's affecting the heart? And then also you're getting a signal in the hips as well. So this appears more to be a systemic process. And is this affecting, like you mentioned, you did a wonderful job going through an anatomical approach, the muscles, the ligaments, the fascia, the tendons, even the chest, the muscles there, the fascia, the ligaments can be involved. So we may have a diffuse musculoskeletal issue. Is it myopathy versus myositis? With pain, you may have myositis. It's still, again, too early, and I will be looking for data to support this thinking at this early stage. So I don't want to invest too much time at this point, but I think I'm looking forward to the next aliquot to see where we can go with any of one of these. So I'm sort of like looking around at various possibilities, trying to generate a hypothesis, but there's nothing really to commit to at this point. So we'll see what the next aliquot tells us.
Yeah, well, what an impressive discussion already, like just from one line. So let's give you some more information.
So to talk about the weakness, this patient first noticed the weakness at work. He works as a construction worker. He found that he had difficulty lifting heavy objects at work at first. And at the same time, he noticed that he had bilateral pain in both of his hands, and then as well as his bilateral knees. Over the course of 1 week, he was not able to lift his hands above his head. He noticed that he had difficulty getting up from a seated position, and he couldn't comb his hair in the morning without experiencing significant pain. Over the course of that 2nd week, he noticed that he started having weakness in his bilateral legs, and it worsened to the point where he was not able to lift either of his legs. His friends actually had to bring him to the hospital because he was not able to walk on his own. And then I wanted to go into the chest pain as well, since everyone's curious about that too. So that started 1 week ago. He describes it as a sharp pain. It wasn't sudden onset, it increased gradually, and it was the worst at the time he presented to us at the hospital. He was sitting down when it started. He says that it happens at rest and also when he's moving around. It's located substernally, and it's described as a heaviness or crushing chest pain that radiates to his back and usually lasts a few minutes. It is worse with exertion and worse with positional changes. So for example, when he's laying down flat, the chest pain worsens. He doesn't have any the only associated factor he has is some shortness of breath that he gets when he's moving around, but no other associated factors like cough, like somebody had asked, and nothing really makes it better.
Wow.
I'll tackle. You want me to tackle? Just I'll mention a few things here. So what's really interesting is this progressive weakness that we're seeing, and we're seeing it not just in the upper extremities, but we're also seeing in the lower extremities. And then there's definitely you could see or adapt system one thinking to a couple of these buzzwords, we would call it, that are in the HPI, meaning not being able to raise the arms up, not being able to comb the hair. It just does bring on a possibility for something like polymyositis, dermatomyositis here, but we're not seeing any skin involvement. So then we deviate from dermatomyositis possibly into the domain of dermatomyositis here. So definitely that is something in the running, but we need to be careful not to invest all of our cognitive energy here into this diagnosis, because there can also be overlap here. And what I'm kind of interested when you were describing the chest pain, if this is some underlying harbinger of coronary artery disease. So occasionally with polymyositis, you may have some overlap with vasculitis. So that also is something that I'm considering. But again, I think this should springboard us to do some autoimmune or autoinflammatory workup to narrow down the possibilities. Considering other myositis, I mean, there's inclusion body myositis, which is proximal but distal. That wouldn't fit this picture. We did have statin-induced myositis last week with during Wednesday's VMR. So if in the medication list there is statin use, that's something we would think about as well. Any other thoughts, Sammy, that you have about this?
No, I thought that was brilliant. When I had the only thing I was considering when I heard like this pain radiating to the back, I always think about the aortic dissection, but the time course it could still be possible, but I would still keep it in the back of my mind, get an ECG, because I'm most concerned about pericarditis, especially with it getting worse when he's laying down. I would also be interested if he has pleuritic chest pain, but I would definitely get an ECG, check for PR depressions, ST elevations, stuff like that, and get a troponin, and especially check for risk factors for coronary artery disease. Is there like familial hyperlipidemia? Does he smoke? Is there like history of diabetes? So yeah, but I'm also like prioritizing more of a pericarditis picture, but I think we still have to prioritize coronary insufficiency. And about the myopathy, I also think that this would be more consistent with polymyositis, but also the peripheral involvement made me think about inclusion body myositis. But yeah, the thing that he can't lift his arms is really characteristic of proximal myopathy. So yeah, I'm very interested where this goes.
Okay, for the next aliquot, for his past medical history, he has a history of hypothyroidism secondary to Hashimoto's thyroiditis. He was previously on Synthroid for that, but he has not been for the past year. He has a family history of hypothyroidism in his father, but he doesn't have a family history for any kind of autoimmune disease, cancer, and has no significant cardiac history like early MI or strokes in his family. He was born in the US, he works as a construction worker, and he denied any kind of smoking, alcohol use, or drug use. For the medications, has been off the Synthroid for some time, no other medications, no supplements over the counter. For his review of systems, he said in the last 2 weeks, he's had generalized fatigue, a new painful bottom lip ulcer that popped up over the last 2 weeks, and then a faint red rash on his cheeks. I also have some pertinent negatives for his review of systems. So he denies any weight loss, no fever, no chills, no like changing of colors in his hands when it gets cold outside, no diarrhea, no dysphagia, and then no urinary changes, like no burning, no foamy urine or hematuria.
And we can just give you the exam as well if you want, or
yeah, sure.
I can like start with it. So he was afebrile. His heart rate was 126. His blood pressure was 120/80. Respiratory rate was normal. On exam, so he was not in acute distress. His arms were flexed towards close to his body, essentially, in his like upper extremities, and he seemed to be like not able to move his extremities, just like from the top of the bed, just looking at him. On HENT, so he did not have any scleral icterus. He did have like a faint red rash on his bilateral cheeks, and he had lip swelling of both of his lips, essentially, with the bottom one that is more swollen than the top one. On cardiac exam, he had no murmurs, rubs, or gallops. His lungs were clear. And then on MSK exam, he had edema in both of his hands. Pain with palpation on his MCPs, his PCPs, and his DIPs. No other papules or nodes noted. And then his nail exam was normal, essentially. And then he also had tenderness to palpation on his wrists and knees with limited range of motion on his hands. Do you want to say the neuro exam?
Yeah, sure. So for his neurologic exam, he was alert and oriented ×4 when we saw him. His cranial nerves were grossly intact. For his motor exam, starting with his shoulders, he had 1 out of 5 strength in his right shoulder, and then 4 out of 5 strength in his left shoulder. For his elbow flexion and extension, he had 4 out of 5 strength bilaterally. His grip strength was 4 out of 5. His hip flexion and extension was 1 out of 5 on the right and 0 out of 5 on the left. For his knee flexion and extension, he had 1 out of 5 on the right, 0 out of 5 on the left. For dorsiflexion, he had 3 out of 5 on the right, 4 out of 5 on the left. And plantar flexion, 3 out of 5 on the right and 4 out of 5 on the left. He had equal sensation bilaterally for his entire exam. And then he wasn't able to perform any cerebellar testing like finger to nose because of the pain that he was having in his hands. His reflexes were just normal, equal bilaterally, and he had a negative Babinski.
All right. I'll start with the southwest corner, and maybe Ravi, you can tackle the more complicated physical exam. But first, just what an expertly done physical examination. Thank you so much. That's so helpful. Yeah, so especially when I saw the hypothyroidism and him not taking the thyroid medicine, I know that hypothyroidism can cause a myopathy. I don't really know more about it, but I would assume that it's more proximal than distal. So I will definitely keep that in the back of my mind, get a TSH. Otherwise, the lacking history of autoimmune disease, of other autoimmune disease, I don't know. I mean, he has hypothyroidism due to Hashimoto, so I think he could still have other autoimmune diseases. Yeah, that's it for that. Another thing I wanted to say, especially with the bottom lip ulcer, I know that especially mixed connective tissue diseases, for example, there is this rare entity of myositis called anti-MDA5 dermatomyositis that notoriously presents with rapid interstitial lung findings, or rapid ILD, and ulcers in the mouth. So that's definitely something we could consider. I was also very interested into the into the nail and extremity findings, if there's any hyperkeratosis or ulcers, but it seems that there isn't. But yeah, that's something I wanted to mention. Otherwise, yeah, we could kick it over to Ravi to help me with the physical exam.
So great thoughts there. I love the thing about the anti-NMDA5. Some very interesting pickups that you have there, Sammy, that it's getting really data heavy now. So I think just sort of pulling back and maybe formulating a problem representation will help us to at least focus on the salient features here. So what exactly is signal? What is noise? What's going to efficiently allow us to invest some memory into getting towards a diagnosis, and what do we need to jettison and not really consider or weigh heavily in the pursuit of the diagnosis and its diagnostic journey. So again, I'm sort of scatterbrained. There's certain things that my mind picks up on. This faint red rash, we're looking at the heart, we're looking at the muscles, we're looking at the hips, and again, with the neurological exam, there's diffuse weakness there, especially in the flexors of the hip. So with this patient, we're thinking maybe muscle, what's common between the heart, the proximal muscles, the flexors is muscle. So what kind of illness will target the muscle? Again, we're thinking myositis, and there's a multitude of different autoimmune conditions that we sort of threw out there, but which one fits? So which sort of illness script fits the picture? But again, was very interesting as this hypothyroidism, which can cause proximal muscle weakness. So I definitely agree with Sammy that in the workup for this patient to effectively rule out the thyroid as the cause of this, we do need to get a TSH. I know with this mixed edema, coma can actually cause a rash, can cause swelling of the lips, so infiltration into the lips, and that can cause even the face becomes edematous. Hypercortisolism can also cause facial edema as well. I also was thinking of angioedema, but I didn't see a quick glance to the meds. I didn't see any ACE inhibitor or ARB there in the picture, or any allergies to medication. So that would be something that I would also think about. Amyloidosis can cause also infiltration into these areas as well. But again, that illness script does not fit the presentation that we have here. Now, again, kudos to both of you, Nidhi and Yusuf, for a remarkably detailed physical exam. So here we are definitely seeing diffuse weakness. And again, cranial nerves are intact, so we're not involving any of the bulbar or the upper motor neuron areas. The shoulder and elbow are all pretty weak. And then we have involvement of the hands as well. So I'm not considering this to be an arthritis, but maybe the tissues peripheral to the joints are probably inflamed, but I doubt this inflammatory process is involving the joints of the hand itself. There are unique features with diseases for the hands that we may have to think about, like rheumatoid arthritis doesn't involve the DIPs. Gout can involve any joint of the hand. And then we have something there with the tenderness within the wrist. So tenderness, is that correct? Tenderness on wrist and knees. So then that also brings me to the point, could any tenderness in the wrist, I start thinking about maybe also something like amyloidosis causing carpal tunnel syndrome. But the knees, again, I'm not sure. I think imaging, if we are concerned, or was there swelling in the knees, or is it just tenderness?
Yes, there was swelling in like bilateral knees.
Okay. So again, that's periarticular, so the soft tissues may be inflamed, but not the knee itself. And the nails were devoid of any abnormality. So that also rules out things like psoriatic arthritis as well. So this definitely does open the door on autoinflammatory conditions. And which particular ones? Again, proximal and distal. I like the thought, Sami, about inclusion body myositis. Again, but the epidemiology doesn't stick. But again, this could be an atypical manifestation of a condition, in that the epidemiology usually is age greater than 50. Other causes of proximal muscle weakness would be GCA. We don't have the head features or the jaw pain, or a very good test is having a patient chew gum. You would have immense pain elicited on that. And the age, again, epidemiologically will be greater than 50. So I think what I would like to do in sort of picking apart the myositis autoinflammatory conditions, the CPK definitely, ANA and some antibody tests would help. And then also looking for any signature in the CBCO chemistry, if there's any cytopenias. The cytopenia would be a huge sign of, say, lupus, or any abnormal chemistry. If there's involvement of the kidneys, could also point us towards a generalized inflammatory condition, again, like lupus. So yeah, at this point, I think let's get some labs and see where that takes us. Back to you, Nidhi and Yusuf.
What an excellent discussion. We need to project you all with us on rounds next time to like generate a differential and things we should do. But yeah, ask and you shall receive.
So his sodium was 136, potassium was 4.3. He had a creatinine of 0.6, white blood cell count of 6.8, hemoglobin of 14, and platelet count of 207. So the rest of his CMP was normal. So normal ALT, AST, bilirubin, alk phos. We did get a CPK as requested, and it came back low. So the number was 42. We also got an aldolase, which was normal. We got an ESR and CRP, which were both elevated. And we also got a troponin, which came back at 3,955. The last thing I heard you guys request was a thyroid function test. So his TSH came back elevated at 42.34. His T3 was normal, and his T4 was low at 0.65.
I think we can also give the imaging as well in this adequate.
Yeah, go ahead.
So The EKG had a normal sinus rhythm with normal intervals. However, it was low voltage and there were ST elevations on V2 to V5. The ED proceeded to get a CT dissection protocol, like Sami was saying, to rule out dissection. It showed no acute aortic syndrome or PE. However, it showed fatty atrophy of the bilateral pectoralis major, right pectoralis minor, left deltoid, and bilateral paraspinal muscles. It showed bilateral pleural effusions as well. Other imaging that were done, like initially, the TTE showed a normal EF, normal valve ratios and gradients, and a moderate pericardial effusion.
So
Yeah, wow. That's a lot of helpful and I don't know, humbling information, I would say. One thing I wanted to say about the physical exam, about the rash, because we were thinking about SLE, dermatomyositis. In SLE, the nasolabial folds are usually spared, and in dermatomyositis, they're usually affected and it can itch. That's like how you can decipher those two. Yeah, that's what I wanted to say about the physical exam. And regarding the labs, yeah, I was really thinking that we would get some kind of signal to like muscle breakdown, but now we have the CK being normal, the aldolase, AST, ALT being normal, which is quite, I don't know. I don't really, I was really expecting a myositis like picture, and it's really humbling to not see it. Otherwise, ESR and CRP suggest inflammation, but the thing that's also like, I'm trying to wrap my head around is the massively elevated troponin. When I think about troponin elevations, first you have to think about like coronary insufficiency. There's like the troponin pyramid. There's like coronary insufficiency. You have ACS. You have chronic coronary artery disease. Second, and we don't have too much signal for that regard, so we have to step up. When we step up, there's like supply-demand mismatch. I mean, he is tachycardic, or he seems to be inflamed. He has some kind of reason to have elevated demand, but his coronary arteries should be able to supply for the demand. So I don't know, I don't really think that that's what's going on here. And on the top of the pyramid, and also the rarest form, is like something infiltrating the myocardium and therefore causing troponin elevations. And there you have myocarditis, you have infiltrative cardiomyopathy, amyloid. I would guess that there's also hypothyroidism up there. And we also get signal for that. The TSH is elevated and T4 is low. I don't know how sensitive that is, but he is hypothyroid. And yeah, then we have to think, okay, we also get signal in the ECG. He has a normal sinus rhythm, but we have these ST elevations and we have this low voltage. When we think about low voltage, is there a pericardial effusion? And we see that there is a moderate one. Always when you have pericardial effusion, check if there aren't signs of like shock, and check for cardiac tamponade. There are sonographic signs that you can assess. But otherwise, if there wouldn't be a pericardial effusion to explain the low voltage, it could also be due to an infiltration. And yeah, I don't know what to make out of the ST elevations. It could be a sign of myopericarditis, especially with the pericardial effusion. Yeah, but I don't know. I have to think a little. I don't know. Ravi, what do you think about the rest, and what do you want to add?
Oh, incredible thoughts. I was just sitting here thinking about my thinking and using what you're mentioning to augment my thinking. So just a lot of the possibilities that you talked about. I really like the analysis of also the cardiac features, and Maddie has a great breakdown of low voltage criteria. So if I'm going to pick something here, now we've been floating a couple of ideas here, and then the TSH being elevated and the T4 being low. We don't really need the T3, but T4 being low, this does scream hypothyroidism. And early on in the process, it is one of the mimics of myopathies. So and then the CPK being normal, that immediately just takes out all the different myositis that we talked about. Although I think with GCA, you can have normal CPK, but then again, I'm not getting that sense here. The illness script does not fit this process, but hypothyroidism definitely does fit. We talked about the muscle weakness. We talked about the patient not being able to get up from a seated position. There's also some skin manifestation. I love the pearl, Sammy, about lupus not involving the nasolabial folds. And then incredible, the itchiness with the rash that you get with dermatomyositis. Yeah, the scalp, I heard, also is very itchy as well, and you have to look up there as well. But we're not getting that generalized sort of Gottron's patches, papules, and heliotrope rash, shawl sign, gun holster sign, all these sort of associated skin findings. But again, they're not all prototypical manifestations of dermatomyositis. But taking the CPK, we can then also rule out a number of different things. You can have, like Sammy had mentioned, inclusion body myositis. Also, you could have anti-synthetase syndromes. You don't have like the mechanics hands. And I'm also not getting a sense of ILD, which can also be part of this process. Now, going to like mimics of myopathies and myositis, definitely the hypothyroidism fits the picture. Earlier on, there was something in the chat about Lambert-Eaton syndrome. So yes, neurological complaint or neurological phenomena could or should be entertained early in the process. But again, I'm not getting the sense of that. I'm getting more a sense of this being a muscular weakness. And then the cardiac, if we do take that and see how does that add to our diagnostic momentum here that Sammy just started, definitely this is gaining traction. That infiltration into the heart, so infiltrative disease can manifest with low voltage here, and then hypothyroidism could be another cause as well. You do get a multitude of different cardiac issues, but I'm not getting the hypothermia, bradycardia, cold intolerance. But again, I've seen many patients with hypothyroidism and maybe just altered mental status without all of those usual typical features that we usually learn about. So I'm going to run with the thyroid here and see. But then again, I'm thinking, what if Nidhi and Yusuf have something up their sleeve that they're just going to bring out and really throw us off track? But my track is laid out, and I'm just rolling with Sammy that we're on the hypothyroid train, and we'll see if that is the path that we need to follow. Back to you, Nidhi and Yusuf.
Sorry, just 1 second. Ravi, I just want to get your thoughts on that. What do you think about the fatty atrophy? I think they want us to mention to talk about that. To me, that like suggests something more chronic and like burnt out. And there was a very good point from Austin in the chat that the CK and the aldolase and the AST-ALD could be falsely negative in the setting of chronic degradation of muscle. So I don't know how reliable these lab findings get to rule out myositis or myopathy.
Yeah, I don't know too much about that. That's where I kind of my knowledge may, as far as if you open up any textbook in the inflammatory, autoinflammatory chapter, I guess the lab testing usually does specify there's elevated at CPK, but then again, these are progressive diseases, right? You may actually catch the patient later on, like you mentioned, and the CPK may be up and down. So you may be catching them on the down phase. So you're right. It's not something we can anchor on and use to justify our suspicion here. So you're absolutely right about that. Now, about fatty atrophy of the pectoralis major, I have to wonder if you do have loss of muscle, it will be replaced by scar tissue, maybe by fat. So there's something going on that maybe, I'm not getting the sense of necrosis here or massive muscle breakdown here. And again, I'm looking back to the CPK, but I'm not seeing it. I'd like to see what the SED rate is as well. That would be very helpful. But I have to then associate if hypothyroidism usually causes this morphological change in muscles. Other things, think about other conditions that can cause muscular change. Diabetic amyotrophy can cause a necrosis, but again, I'm not seeing in the past medical history if there's any history of diabetes or anything like that. But let's see. We'll learn from Nidhi and Yusuf. And always remember, it's the diagnostic journey, not always the final diagnosis.
Exactly. And that's what we were thinking too, is that your journey that you're taking us on is very accurate. You're on the right track, and everything you're saying is like exactly what was going through our mind. And that's what I wanted to ask you, actually, like putting you in our shoes. What are you doing now? And are you calling someone? Are you ordering a test? What would you do if you were taking care of this patient right now, Ravi and Sami?
Yeah, that's very interesting thought. I mean, I'm still not convinced that this isn't like some kind of mixed connective tissue disease going on. We have, to me, this is polyarthritis. He has tenderness and swelling in his wrist, in his knees, in his fingers. So I would call that a polyarthritis. I would also call it a polymyositis-like picture without CK elevation. Not that occurred, but I still think that the mixed connective connective tissue disease is possibly, especially with the rash. I would get ANA, all the subtypes with the other nuclear antibodies and stuff like that. I would get a complement. I would maybe get an MRI to check if there's active inflammation going on somewhere. You can also grade perimesial, endomesial inflammation, and then get like, there was a very good tweet from Zavin, I think 2 weeks ago, that the pattern of like inflammation in myositis can be very focal. So when you get a random biopsy, you can miss it. So I think an MRI would be appropriate to get and check if there's active inflammation going on, and then go for that muscle and try to biopsy it, and especially do consultations, consult endocrinology, rheumatology, cardiology for the elevated troponin. And yeah, that's what I would do. Ravi, what do you think?
Well, Sami, I have nothing to mention. You pretty much had declared all the testing that should be hopefully helpful in getting to the diagnosis. So everything that Sami said is absolutely the workup I would do, and then just tag on the auto or the myositis associated antibodies. And let's see what I'm kind of interested. I don't know, MRI before a biopsy would be helpful. Back to you, Nidhi and Yusuf.
Yeah, excellent. So first, we called cardiology, initially given like the troponin elevation, ST changes, and they were also like concerned for a myopericarditis, like Sami was saying. They recommended starting NSAIDs along with colchicine, and then work up, as you were saying, like working that up for etiologies, but in the meantime, starting therapies for myopericarditis. Endocrinology was also consulted, and they recommended like supplementation with thyroid, treating the thyroid dysfunction, essentially the hypothyroidism. And then we ordered a few labs that started coming back in. If you want to like,
yeah, sure. Yeah. So after we started him on the NSAIDs and the colchicine, his troponin trend went down. So he had originally presented with 3,900, went down to 3,700, and then by the next day he was at 172, and then down to 107. And then we did get some advanced labs, like Sami had said. So we got an ANA, which came back as 1 to 1,280. And he also had low complement levels. So he had a low C3, low C4, and low C50 as well. And then we thought that to also get just some relevant infectious disease labs. So we got an HIV, which was negative, RPR, Hep B and Hep C, EBV, Bartonella, CMV, histo, and then a quantiferon, all of which came back negative.
And the next aliquot will reveal the diagnosis.
Sami, take a stab at it. There's some amazing labs there.
Yeah, that's very helpful. So we were kind of thinking about the myopericarditis, and I think starting NSAIDs and colchicine would be like, as they did it, is like the appropriate thing to do if you are concerned for like an inflammatory process. And as we see the troponin downtrended, what's like also supports this notion that either it was an autoimmune myopericarditis or maybe also an infectious one. Yeah, about the ANA can be elevated in a lot of instances, and can be very unspecific. I think 1,280 is already like, I think only 3% or 2% will be positive, falsely positive. So that's already a high titer. So it would definitely look at the subtypes to check if there's like anti-double-stranded DNA, Smith, RNP, yeah, going in that direction. And the complement is kind of helpful, because if this is like an lupus flare, you would expect low complement. The thing that doesn't fit for me is like, I mean, he doesn't really have cytopenias, which you would expect, but I think I guess patients don't read the textbooks. If this is like a real lupus flare, I would also get a UA, check if there are red blood cells in it, protein, if there's any signal for glomerular pathology. Yeah, otherwise I was also thinking, I mean, SLE in a younger male wouldn't be so typical. I was also thinking, is this maybe a mixed connective tissue disease? I mean, we have signal for polyarthritis, we have signal for lupus with this rash in his face, we have signal for polymyositis, rheumatoid arthritis. I mean, I would definitely want to be interested in the RNP antibody. Yeah, but that's basically everything I got. Otherwise, also think about infectious endocarditis, although maybe I would get blood cultures can cause an elevated ANA, can decrease your complement levels, but this would fit, but would be a little bit atypical. Yeah, that's what I would be thinking. Ravi, help me out.
Whoa, Sammy, that was amazing. That was, I love that you had gone through picking apart all the different manifestations of putting together, that they don't fit just one autoimmune disease, but many different others. So I definitely was thinking, wait, are we dealing? So this data can lead you down a slippery slope of just lupus, but you got many different sort of manifestations of other diseases. So with mixed connective tissue disease, although 80% usually of this, we have a 39-year-old male, but usually it's women. But in this case, again, the 20% would be male, so it could still fit the picture. But lupus by itself, it wouldn't explain the autoimmune myositis that you may have in this case. You may have also Raynaud's phenomena. You may have also involvement of the heart with myocarditis. Pericarditis does fit the picture with lupus. So I think definitely doing a workup for the anti-U1 RNP antibody would be helpful in this case. I'm not sure if we are dealing with that, but I just definitely was thinking about that, thinking about my thinking when you were working your way through the different possibilities for this patient's presentation. Back to you, Nidhi and Yusuf.
Excellent discussion.
Okay, yeah, sure. So I'll tell you some of the room panel that came back. The anti-Joe was negative, but his anti-Ro and anti-Law antibodies, anti-Smith, anti-U1 RNP, CCP, SRP antibody, and MI2 beta antibody all came back positive. So our final diagnosis was mixed connective tissue disease with features of lupus, myositis, complicated by myopericarditis. So Sammy, you really hit the nail on that one.
Whoa, Sammy, that was so good.
What a case. Wow.
Excellent.
I'm just so, I don't know, intrigued.
Yeah, I couldn't even imagine. This is a real world case where you have so much immense, I mean, so many different manifestations of presentation, and then you have so much data, and to then sort through the data and really cut through like a butter through I mean, like a knife through butter to get to the diagnosis is very exhausting, at least. And in the real world, a lot of this data doesn't come back instantaneously like you so eloquently presented this case. So it's like every day you're changing your thought pattern. Then if you're getting a lab test that's negative, then you're ordering more lab tests to refine your diagnosis and try and get to a possibility here. So it's just incredible the amount of work that you did in trying to work up this patient. But how did this patient do after you made the diagnosis?
So I wanted to discuss a little bit about what happened in real life, because this was actually two different presentations. We just combined it in one. So when he first presented to me, he had the weakness, and at that time we thought it was hypothyroid myopathy because we didn't have any of the room panel back. He actually didn't have that severe, he didn't have the pericarditis at that point, and he didn't have the oral ulcers and some of those things that made us think that there was something autoimmune going on. So we actually started him on Synthroid, and he got better while he was in the hospital, and he went home. And then a few weeks later, he came back in and ended up on Yusuf's team.
And at that time, he was completely unable to move any of his extremities with actual like full flare of myopericarditis, which is all of this presentation that we reported here. So we sort of had a little bit the test of time, a little bit for some of the results to come back as well to help us with this diagnosis. And we can share what, other things that happened in this hospitalization. Between the in the interim, his TSH improved, his T4 improved, his T3 improved, but the weakness and the myocarditis persisted. So that helped us also differentiate between the two. And we consulted rheumatology, who also tapped one of his knees, who just showed an inflammatory knee, but without any crystals, or white blood cell count was about 10,000 almost. The patient was started on methylprednisolone steroids, and his weakness significantly improved. We discussed this with rheumatology as to like the exact questions like you're saying, like why is the CK normal, why is the aldolase normal, and like you all cleverly picked up is that sometimes you don't sometimes the CK can be like a troponin. If the muscle is injured right now, you would catch the injury. But if a muscle injury occurred in the past, like in heart failure, for example, you don't have persistent troponinemia because it's a marker of muscle injury, like you're saying. And the CT further supported that hypothesis that there was a muscle injury in the past, and therefore his weakness was released the CK at that time. Additionally, two other pearls that was like very interesting to me was that myositis associated with anti-SRB antibody tends to be hyperacute. And the way the fellow reported was that one day you're playing soccer and then like 2 days later you can't walk anymore, which is exactly like so what happened here. And lastly, lupus syndromes are much more rare in men, but are more severe when they present, which also supports this presentation as well.
And then we just had a quick teaching point on mixed connective tissue disease. So it's a pretty rare diagnosis. The prevalence in the United States, there was one study done that showed it might be 2 in every 100,000 adults per year. There have been some other large studies that have been in Japan that suggest it might even be more rare than that. And like you guys picked up in the beginning of the case, it's a lot of these autoimmune conditions predominantly happen in females more than males. And in one study, they showed that the ratio might be 3 to 1 females to males. And the mean age of diagnosis is usually 40, and our patient here was 39. There hasn't been a clear mechanism that has been identified for mixed connective tissue disease, but one of the proposed theories is that molecular mimicry is involved. And usually the initial presentation is nonspecific. So sometimes it can be difficult to pick up all of the different like symptoms that are going on. So there are a couple of criteria that have been proposed for mixed connective tissue disease. One of them is a positive anti-RNP antibody, and it has to be at a certain level or titer. So for our lab, it was greater than 120. And to give you an example, for our patient, his was 684. You also need to have myositis or synovitis plus 2 of the following: edema of the hands, which I didn't know previously and was something that our patient presented with, synovitis, myositis, Raynaud's, or sclerodactyly. So our patient met that criteria for mixed connective tissue disease.
It's just such a great explanation there, Nidhi and Yusuf. Is just listening to you now, it's like, oh my gosh, this just fits the picture. It's just so apparent now. But having to work through this, Sami, it was like I felt like my head was hitting a brick wall. I was like, oh, okay, it has to be this. But that the complement of the ANA, I mean, that ANA was insanely high, so it's screaming there has to be lupus in there, or something along one of the associations with lupus, I guess. But yeah, that was a great thought about mixed connective tissue disease, and then putting it all together under one umbrella, which is mixed connective tissue disease. I kind of did look up. I was like, wait, does this thyroiditis connect to this? And I found something that this actually could have been an early manifestation of this. So the thyroiditis was just the first step or the index presentation of this condition. So it's just amazing that following the patient and seeing him at 2 different presentations, I think I would have done the same thing. perform premature closure with, okay, the thyroid can explain a lot of this, but when you treat the thyroid, then you're left with all the other stuff. But again, at the second presentation, the patient would add other manifestations that would have alluded you to possibly another autoinflammatory condition. So really job well done, really well presented, and Nidhi, a great explanation. You'll be a fantastic resident teaching all your students and interns. So I would give yourself a pat on the back. Sammy, any final words or reflections?
Yeah, I don't know, I'm speechless. This was such a thoughtfully presented case and so expertly. Thank you so much. It was so great and it felt so good to discuss through it, and I think we all learned so much. I will have to go back and read more now, and I don't know, that's just the beauty of VMR and coming here together and learning together and having people like you presenting these cases. That's just such a privilege. So really thank you so much, and everyone who has been here and also in the chat. And yeah, what a journey. I mean, first the hypothyroidism, then it doesn't get better, then we get the signs of inflammation, doesn't really fit it, then the CK is normal, then we see the fatty infiltration, then we think, okay, maybe it is myositis, and then at the end having all this room workup coming back positive. Yeah, what a journey. Thank you so much.
Deborah, lead us through the teaching points. Take us home, Deborah.
Yeah, thank you so much, Nidhi and Yusuf, for this case. It was really great. Thank you, Ravi and Tammy, for the discussion. So going for the teaching points, the chief complaint with weakness and chest pain, we thought about that if the weakness can be more proximal, we thought about a myopathy, or if it can be distal, it could be a neuropathy. And we thought about the chest pain, if we did the differential between if it's pleuritic or not, change with the position of the patient, if it happens in the rest. And then we thought about the polymyositis, that could be the muscle weakness in the shoulders and hips. And in this case, we thought because it was hard for the patient to raise the hands over the head, and the patient in the beginning didn't show any skin manifestations, so make us more far away from dermatomyositis. And looking for the hypothyroidism, that could be the cause of the proximal muscle weakness, even if the patient was not taking the medication. So it's good to check for the TSH. And one autoimmune disease can make the patient have even more. And in looking for the EKG, we have a low voltage that could be like a pericardial infusion, or could be a manifestation of the hypothyroidism, or like other infiltration diseases. And I have the pearl about the difference between the rash of the dermatomyositis and lupus, that the lupus can typically spare the nasolabial folds, and the dermatomyositis normally involved. And then we have some great pearls about the mixed cognitive tissue disease, about the criteria that has to be a positive U1 RNP, myositis, synovitis, edema of the hands, renal, and sclerodactylia that normally happens in people with the 40s. And it's a rare disease that normally has a molecular mimic involvement and happens more in women than men. And Yusuf gave us a pair that the lupus syndrome is more rare in men and can be more aggressive, like it was in this case. So yeah, thank you so much. It was great to learn more about this disease. And yeah, I see you all tomorrow.
Thanks, everyone. Take care.
Bye, take care.
Bye.